So this will set pace for us to invite Dr. Ibrahim Wada, the CEO of Nisa Medical Group. He's going to talk on something that is also very passionate to him, which is the reason for setting up this Nisa Medical Group and also organizing Nisa Medical Week outreach. Dr. Wada is going to talk on reversing medical tourism. Before I invite him, I'd like to just read a little bit of just summarize because you can't discuss Dr. Wada. You can't just talk about him in a jiffy. Just few lines of Dr. Wada. Like Dr. Lanre said, Dr. Wada is the founder and chief executive of Nisa Medical Group Abuja. Dr. Wada trained in ABU Zaria and it had his residency training in Jos University Teaching Hospital. And also he's trained in Cambridge and Queen Elizabeth Hospitals, Kings Lynn, UK. He's a fellow of the FRCOG. And Dr. Wada is also a fellow of the West African College of Gynecologists. Also, Dr. Wada founded Nisa Premier Hospital, which has achieved breakthrough live birth of baby Hanatu in 1998. I'm sure a lot of us know about these events and several other breakthroughs he has also accomplished in his path of career. Dr. Wada was once the pioneer medical director of Gariki Hospital, and he is also the pioneer of public-private partnership concession with the FCT administration that had Gariki Hospital together. And that is the first of its kind in Nigeria. Dr. Wada is currently an associate professor at Atahiru Bayero University, ATBU University, Bauchi. He's also a board member of the African Federation of Fertility Societies. He's a medical advisor to the International Committee of Monitoring ART, that is Assisted Reproductive Technology. And he is the past president of AFRH, Association of Family Reproductive Health in Nigeria. Dr. Wada is a recipient of National Award of the Officer of the Order of Nigeria, that is OON. He has authored more than 20 academic peer review papers and published 2 books. Ladies and gentlemen, I invite Dr. Ibrahim Wada to talk on reversing medical tourism. Dr. Wada, please take over from here. Thank you.
Hello, NJ. Thank you very much for this very lengthy introduction. I'm very happy and honored to be here, especially when I have very, very good colleagues who have achieved very great things in the United States of America, come to talk to us at home and also come to work with us at home to try to up the game of Nigeria and make more of the treatment of our nationals occur here in Nigeria rather than going abroad. So reversing medical tourism is just a few comments about it that I want to make. Can anyone see the slides that I'm sharing?
Yes, we can see it, Dr. Wada. Please go ahead.
Okay. Thank you very much. So, yes, that's right. Put it on presentation. Thanks. So I've been well introduced. One of the strengths of Nigeria is that we have thousands of Nigerians in different parts of the world. In fact, every part of the world. And amongst them are highly trained, well-experienced doctors who we all know have a big role to play in importing to our country knowledge and skills that they can hand over to patients in their treatment and also hand over to their colleagues in trying to bring their colleagues up. But the problem of our country has always been how best do we utilize this great resource and bring our people abroad to our homeland. These are some of the issues, whether it's security, whether it's our economy, whether there are opportunities for training, and so on. The thing I say about these reasons is they are the same as they were many years ago when I left England to come to make my own contributions to Nigeria. And Nisa Medical Group is probably one of the legacy things that I've added value to. The key is that someone in the diaspora will have something special to come and offer at home. In our case, it all started with IVF, but has been expanding. And we are very fortunate today that we have experts in gastrointestinal, endoscopy, experts in weight loss management and surgery, who have come to add to the retinue of all the things that have happened so far, including kidney and heart work. And it's for trying to engage with the diaspora that we formed NEMSTA, a network for medical skills transfer to Africa that we hope will be a vehicle that will help a lot of the people that are coming. This is not just for Nisa, but Garki Hospital is part of the hospitals under the care of Nisa. Please mute yourselves, anyone. And this kidney heart transplants, you can see how that hospital has been able to accommodate. They also do a lot of orthopedic surgeries too. And for us to engage with the diaspora successfully, there's a lot of planning. And that's why I thank Uchenna, members of the NEMSTA group who have planned today and the clinical engagements to follow. They planned it so well. Thank you very much. And I believe, I'm very sure that Dr. Austin Osemeka and Dr. Ayoola, they're going to really wow the Nigerian scene and add value. So in trying to make progress, we've brought a lot of innovation to bear on the country. You can see the top program here, the top picture here is the Nisa International Medical Center that's coming up in the next few months to add its value. And this is the kind of environment we are bringing these experts who come from abroad to Nigeria to work, seamless environment that should look like where they're already practicing. The middle picture shows the Nisa Wellness Retreat. This is the place they stay, so they feel at home. They feel enthused to give the best of what they have. The last photograph here shows one of the wards at the present Jabi Hospital. It's very inviting. So even our patients can look forward to everything that can happen abroad. And I say very quickly that with everything you've seen, it shows that Nigeria can actually reverse medical tourism, not just that, attract people from other countries to come to Nigeria to get treatment. And so the motto, which I say, Nigeria can, Africa can, is what is playing. And I want to once again thank Folahan Ayoola and Austin Osemeka. I want to thank the Nisa Medical Group team who have made this to function, and the NEMSTA team, and all the people that are listening today to the great minds that have come to talk to us from the United States of America. Thank you very much for the opportunities. God bless you all.
Okay, can we give Dr. Thank you very much. Thank you, Dr. Wada. I know you're so passionate about reversing medical tourism in Nigeria because you believe that whatever is that they have over there, we have it, we can provide them in Nigeria. Thank you very much. Another round of applause for Dr. Ibrahim Wada. Thank you.
Thank you all.
Moving on now to the reason we all gathered here.
There must be a way to mute everyone so that people don't talk cross.
Please, can you mute yourselves? Thank you. Can you mute?
Please mute your microphone.
Mute your microphone, please. Victor, please, can you mute? Can you mute him? Thank you. Except you want to talk, please, for those participating online, except you want to speak, please mute, have your microphones muted always, and raise your hand to tell us you want to speak, please. And the opportunity will be given to you. Thank you very much. Now, the reason we are here two renowned surgeons that had decided to come back to Nigeria to come and help us here with their skills, transferring their skills down here to Nigeria, especially here in Abuja. We're going to have an expert presentation by Dr. Ayoola Folahan. Dr. Ayoola Folahan is a bariatric surgeon. And I just want to read a little bit, an abridged version of his bio. He completed his medical school at the University of Texas Southwestern Medical Center in Dallas. Dr. Ayoola had his residency training at the Virginia Commonwealth University. At that Virginia Commonwealth University, Dr. Ayoola was given the highest award that any surgical resident had ever had during his program, and that is the IA Bigger Award. This is just to say that he talked about his integrity, his leadership skills, teaching, and clinical abilities. After his residency, Dr. Ayoola stayed back at Virginia Commonwealth University for additional fellowship training in bariatric surgery and minimally invasive surgery. Dr. Ayoola practices at Texas Health Presbyterian Hospital in Flower Mound, Medical City, Frisco, and Baylor Trophy Club. Dr. Ayoola is the medical director of bariatric surgery at Texas Health in Flower Mound and serves on multiple steering committees at the Medical City, Frisco. He is a speaker of multiple weight loss pharmaceutical companies. He educates physicians on safe and efficacious use of these drugs. And the American Society of Metabolic and Bariatric Surgery, where he has served on various committees. He is board certified in general surgery with fellowship training in bariatric and minimal invasive surgery. Ladies and gentlemen, this is Dr. Ayoola Folahan. I always call him our own Dr. Ayoola Folahan. Yes, he's in US, but he's our own Dr. Folahan. Please make welcome Dr. Ayoola Folahan, bariatric surgeon, to talk to us on bariatric surgery overview. Thank you very much. Dr. Ayoola, you may now take it from here. Thank you.
Thank you. Thank you so much. I appreciate the opportunity to be here speaking with you all. Looking forward to being with you in person, and looking forward to taking care of my brethren and essentially family in Nigeria in general. So I'm just going to share a brief overview of what I do with you and what we plan to accomplish when we're in country. Can you see my slideshow? Okay, I think I can see it on your screen there. So what I do is help people lose weight.
Yes.
If you look at life insurance data, it says that if your body mass index, which is a ratio between your height and weight, if your body mass index is between 19 and 29, you live longer. The ideal BMI is just under 25, but you're okay up to about 29, and you're okay on the other side down to about 19. So if you're curious about what your BMI is, you can go online and Google BMI calculator and just punch in your information, how tall you are, how much you weigh, and it'll give you a number to let you know what your BMI is. So life insurance in the US had looked at how to identify who would live long and who may die prematurely. And one of the clearest things they found was that if your BMI was above 30, your life expectancy continued to decline. So you see in Nigeria, a lot of times people dropping dead at 50, 55, and people always blaming witchcraft and other things. Sometimes it's as simple as your BMI and your health status. And so if you ignore these things that are very quietly affecting you, it doesn't mean they don't still affect you and cause problems. When you also look at quality of life, People live better when their BMI is between 19 and 29. I spend a lot of time on this slide when I talk to people because this is the whole reason why we do this. Yes, people may feel like cosmetically they look better when they're slim, they fit in a tuxedo, a dress, a suit better than they like it. But the key thing is to help you live longer and also help you live better. So there are lots of societies that have looked at how to lose weight. It's lifestyle, medication, and surgery. The three options we have to accomplish weight loss. Lifestyle by itself will usually lose about 11 pounds or 5 kg long term. Medications will lose anywhere from 24 to 32 pounds, 35 to 48 pounds, depending on whether you're using pills or injections. And surgery will lose over 50 pounds and up to 250 pounds. Sorry, we use pounds in the US, so I'm more familiar with using pounds, but you can divide that by 2 on average to get what your kg is, if I'm not mistaken. So for people that have a BMI over 30 with medical conditions like diabetes, high blood pressure, sleep apnea, arthritis, they should consider surgery and are eligible for it. And people with a BMI over 35, even if they don't have medical conditions, should look at surgery. Since that's what we're coming down to do, that's what I'm going to focus my talk on. When we talk about surgery, what we're going to start with when I come to Nigeria is doing this first operation called the sleeve gastrectomy. So that's what I'm going to focus on. We look forward to doing gastric bypass and duodenal switch. These are more complex operations that need more complex attention during surgery and afterwards as well. If you are a candidate for this, we can discuss how we can accomplish this, but the timing may not be this first visit to Abuja. So if your BMI is under 50 and you don't have a lot of heartburn and you are not on insulin for diabetes, the sleeve is a good option. Once you start having heartburn or reflux or diabetic with insulin, we start looking at the gastric bypass. And if your BMI is over 50, or if you're severe diabetic, or you're needing revision from one of these operations, or you have a one and done mentality, then we look at the duodenal switch, which, as I said, is a more aggressive operation. The sleeve gastrectomy is very straightforward. That's why it's very popularly done around the world. It's the most common operation done because it's so simple and straightforward and has such a low risk. The operation involves removing a portion of the stomach, reducing the amount of food that makes you feel full, and it also reduces a hormone called ghrelin that stimulates hunger. So you feel less hungry, you get full faster, so you lose weight in a very comfortable way. It will lose up to 50 to 100 pounds routinely. So as I said, it's good for patients that don't have heartburn or reflux, no diabetes, with a BMI under 50, average weight loss 50 to 100 pounds. The success rate is 80%. It's good because it's very low risk. It's bad because about 10% of people can develop heartburn, and about 20% of people can regain their weight if they're not careful with their diet afterwards. The operation takes about 30 minutes to do. You spend one night in the hospital routinely, and the recovery is very straightforward. No driving for a day or two, back to work in 1 to 2 weeks, and just don't lift anything more than 15 pounds for 1 month. The diet after surgery is liquids for 1 week, and then soft foods, anything you can mash with a fork for 3 weeks, and then back to normal food. The risks associated with surgery are less than 0.5%. All right, I'll be there. Less than 0.5%. And the risks are bleeding, infection, obstruction, which are very infrequent and we know how to treat. Bleeding requires blood transfusion, infection requires antibiotics, and obstruction really doesn't happen anymore because we have learned how to do the procedure without causing those kind of problems. Hair loss is possible, but it's actually not common, and it usually resolves within 6 months after surgery if you're taking your protein and your vitamins. Here's a picture of a couple of my patients that had surgery, and you can see that they lost a fair amount of weight. One of the things that I always address is that there's a lot of fear involved in having surgery. Everybody gets scared, and that's normal. And this patient was scared, but she was also unhappy with herself. And after surgery, she's forever grateful because she's doing very, very well. She and her husband are both doing fantastic. And this is very typical of what people experience. There's fear up front, But eventually, after surgery, when people see that there's nothing bad happening, there's just gratitude. So these other slides are for here, but obviously we'll be doing this in Nisa, and so those slides are not as relevant. So I'm going to stop the sharing here. I am not sure if Dr. Osemeka is taking over now to do his part, and then we can have Q&A, or if we're doing Q&A for me now. Obviously, if I do Q&A now, we could potentially go forever. So I'd give Dr. Osemeka the stage to do his presentation. Thank you.
Please a round of applause for him. Thank you very much, Dr. Ayoola. Dr. Osemeka, are you ready? Dr. Osemeka, are you ready? Okay, while we wait for Dr. Osemeka, Dr. Ayoola, will you be kind to take some questions, maybe from both online participants and the people we have here physically? Is that okay for you?
I'm sorry, could you repeat that?
While we wait for Dr. Osemeka to join us and give his presentation, is that okay for you to take questions?
Yes,
Well, I'm here.
Okay.
Oh, okay. So, Dr. Austin, hi.
Hi.
Okay. So you're ready?
Yes.
Okay. So I just want to talk about Dr. Austin. Dr. Austin Osemeka. He graduated from University of Ibadan. He traveled to USA 2 years post-graduation to go do postgraduate studies. And that is how we lost him till now, that he's not trying to come. Okay, so he's been practicing for 27 years with special interest in endoscopy. Dr. Osemeka is going to talk on the overview of GI procedures for some of our patients who's going to go through that procedure. Thank you, Dr. Osemeka. You may take it from here. Thank you.
Sorry, I'm trying to make sure that, can you hear me?
Yes, we can hear you loud and clear.
Okay. Thank you, NJ, for the introduction. I'm Dr. Austin Osemeka. Actually was, as you know, was born in Lagos, grew up in Nigeria, went to University of Ibadan and finished in 1986. That's a long time now. And eventually, after my house job and youth service, left for the United States. At that time, a lot of people were leaving for the United States, not because it was better. Hello? Are we there?
Yeah, I can hear you.
Please go ahead. We can hear you.
Okay. A lot of people were leaving for the United States at that time, mainly for postgraduate studies, because Nigeria wasn't as bad as this. I remember we went to medical school. We were being paid by the government at that time. I tell you this story because it forms the basis of why we've all decided that we need to come back and build our country. To make this very easy, I'm gonna divide my little talk into 3 areas. The first is where are we coming from? The second will be where are we going to? And the third one will be Nigerian healthcare. As most of you will realize, when I came to the United States, I did my residency, which is a 3-year course, and then had to do another 3 years to become a
Dr. Austin, please,
gastroenterologist.
can you give me a second, please?
Okay.
Ruth, please, can you mute yourself? Thank you. Dr. Austin, please go ahead. I'm so sorry about that. Go ahead.
So I had to do 2 programs, the internal medicine, which is general medicine, and the specialty, which is the gastroenterology. What exactly is gastroenterology? For those of us who are not in the medical field, that's the division of medicine that deals with the digestive system. And as most of us know, most of the digestive ailments are very common in Nigeria. But my special interest is in endoscopy, liver diseases, as well as pancreatic diseases. And I've spent the last 27 years practicing in the United States, mostly in the area of endoscopy. Why is it important that we come back to Nigeria? In my 27 years of practice in the United States, at least every year, I get 10 to 15 Nigerians that come just to have procedures done in the United States. So that tells me that there is a huge need for us to make it easier for people to have access to the care that we can provide. Instead of them having to come to the United States, we can come to Nigeria and provide the same care. Remembering that Nigeria is our own motherland, no matter how much we do or make here, we have to develop our own motherland. It was in this quest that we collaborated with Dr. Wada, who has done marvelously well in Nigeria. Remember, he left the United States, he left England and came to Nigeria. And at that time, most people thought he would not be able to succeed. And he has made a wonderful progress in the area of fertility. It's in this light that most of us have now decided that we're not going to wait anymore for the government to initiate these programs, but we will come and join private enterprises, especially hospitals that have the same vision, and which Nisa is a premier leader in this area. And that's why we've collaborated with Dr. Wada and Nisa Premier, forming the NEMSTA, which is the medical transfer of medical technology to Africa. In this light, I have personally devoted the last 3 years in trying to develop endoscopic procedures in Nigeria and make it as affordable as possible. Why is this of importance to us? It's not that people are not doing procedures in Nigeria. A lot of people can try to do endoscopy procedures. However, we have to make sure that the quality metrics are the same standard as we have in the Western world. We have to make sure that it's safe, and we have to make sure that we can compare our results such that we can develop the Nigerian sector also. A lot of people often ask the question, why would you come from the United States just to come and do endoscopy in Nigeria? Well, 2 reasons. The first reason is we have to make sure that it's done well, and we have to make sure that it's safe to our people. And it's in this light that we're going to collaborate with our colleagues in Nigeria to make sure that we have the same standards. Very, very quickly, I'll go over some of the endoscopic procedures that we're anticipating to perform when we come to Nigeria. As most people know, ulcer disease is very common, or at least people think they have ulcer disease, and very often are treated with multiple medications that sometimes do not improve their state. We will be able to make sure that somebody comes down at least once a month or once in 3 months to continue the good work there and perform upper endoscopies where we look inside your stomach. The second area we're interested in is in colon cancer screening. Screening in Nigeria is a little bit rudimentary because we wait until we fall sick before we get help. However, the studies have shown that when a society is screened, their health is much more improved. And in this case, everybody above the age of 45 is entitled to colon cancer screening with a colonoscopy or checking the stool for blood. Other things that we're looking to perform when we come around will include control of bleeding in patients that may have bleeding disorders, especially those that involve alcohol. A lot of patients who drink alcohol may develop what we call varices in the esophagus. And we've seen that quite a number of those people die from their disease. Would also be able to perform what is called capsule endoscopy. That's when you swallow a little camera, and this camera can take pictures of your intestine, your stomach, as well as your large intestine, and we can watch in a computer and be able to make diagnoses of diseases that are not necessarily easy to diagnose. A lot of patients also may have things like gallbladder disease as well as pancreas disease, especially pancreatic cancer. We hope to be able to provide ERCP, which is endoscopic retrograde cholangiogram. Now, these are big words, but you don't have to worry about them. Just know that for somebody who has a diagnosis of either liver or pancreatic disease, we might be able to help them by putting in stents in their pancreas or in their liver in this procedure called ERCP. So where are we going? What we want to see is a situation where there is no need for anybody to die in our society in Nigeria just because they cannot access healthcare abroad. More importantly, there will not be much need for you to go abroad and spend so much money only to have a lot of times bad outcomes because it's too late by the time you present abroad. I will not be happy to be called a Nigerian and see my people continue to die just because there's no access to care. So in this program that we're developing with in NEMSTA, in collaboration with other people that are interested in having the same goals as we are, as you've seen Dr. Ayoola, he's coming down. There are other surgeons that will be coming down also. We want to make sure that access to healthcare will be there for most people that can, at least afford a little bit of payments. The cost of these things are not going to be too exorbitant. We're sensitive to that. And more importantly, we will be able to make sure that we prevent unnecessary deaths in our society. You can live in America for all you want. You're an American, but you're first a Nigerian. And that is why, if we don't do it, who will do it? And I will stop at this time and maybe take some questions if we have to. Thank you very much.
Please a round of applause for Dr. Osemeka, the soft-speaking Dr. Austin Osemeka. Thank you, Doctor. And thank you for that passion to come home and give back to your people. I know that some of our patients, both some of the people that are here, both online and here present, been itching to ask one or two questions. A lot has reached out to me talking about how they feel, and I'm trying to get kind of confirmation that it's safe for them. So right now we're going to go into questions and answers. I think we should start from the people online first. We should start with the people online. Please, can you let me know if there's, and if you have any question, can you raise your hand and let us know, or you type it in the chat box? What it can help you do is to check out the questions on the chat box. Or if you want to talk, you can request for access. We'll allow you to ask your questions. Please, whatever area, either on the bariatric surgery or on the GI procedure. Do we have anyone? Do you have questions on the chat box? Yes. Does anyone want to ask questions?
Yeah, I have a question.
Okay, ma'am. Please, can you introduce yourself? Let's meet you.
Okay, I'm Nurse Blessing Wachuku from Nisa Premier Hospital.
Okay. Please
My
go ahead.
question is for our own doctor.
Is it from us or here? From her end. Okay, while we wait for her connection to get better, do we have any other person? Okay. Thank you. Can I read the question? My name is there a way you can help me look at the question or write it out for me, please? Thank you. And I think she's back. So can you go ahead, Ma, and ask your question, please? I think I need to be with one of the devices. Thank you. Thank you very much. No, please come. Okay. My name is Nurse Ejiga. If you are from a family that are all on the big size, you inherit your size from your parents, can you still go ahead with the weight reduction program? That is the bariatric surgery without negative effects?
So this is Dr. Ayoola. Thank you for that question. I hope you can hear me well. Your number one, you're correct that there's a familial component to weight. So if both parents are big, then there's a higher likelihood that the child will also be. In fact, this is one of the best times to use bariatric surgery, weight loss surgery, because other methods like diet and exercise by itself and even medications are usually not successful. And so this is exactly what bariatric surgery was designed for. And this is a great candidate for bariatric surgery. Again, thank you for your question.
Thank you, Dr. Ayoola. The second question we have to read now is from who? Okay, so Dr. Ayoola, I think this is for you. What is the difference between the bypass and the sleeve, and how long will one stay in the hospital?
Thank you for the question. The sleeve I showed a animation of is strictly working on the stomach and removing a portion of it. The bypass is different because you work on the stomach and on the small intestine. And that's why I said it's a little bit more complex of an operation, because you're not doing just one thing or working on just one part. You're working on the stomach and you're working on the intestine. So what you're doing is you're dividing the stomach into two, a very small stomach pouch and a larger stomach section that you won't be using. Let me see if I can actually just share you a screenshot so that you can see what the operation entails. But basically what you're doing is making the stomach a smaller section, a smaller pouch. And after you do that, you reroute the intestine so that not all of the intestine has the ability to digest food. So you're diverting some intestine away from the stream of where food would meet it. And so that's the difference between the two operations. One is purely stomach, whereas the other one is both stomach and small intestine. I hope that answers your question. If you need additional clarification, I can provide that, and also provide the animation of what the gastric bypass looks like. The stay in the hospital is the same. They're both overnight stay. So there's no extra time spent in the hospital.
Okay, thank you very much, Dr. Ayoola. I think we have one more question or two more questions from the online participants before we come back home to the people that are here with us present. The question is, good afternoon and thank you for the two insightful sessions. My name is Halima Oyelade. How do I book to see the gastroenterologist when in Nigeria? Secondly, can one use medication instead of surgery because the intended weight loss is about 5 to 6 kg? So one is for Dr. Austin and one is for Dr. Ayoola. So Dr. Ayoola, Can you please answer how can one use medication instead of surgery because intended weight loss is about 5 to 6 kg?
Yes, if your intended weight loss is minimal, less than 40 pounds, which is about, I think, 15-ish kg, you can use medication. The one thing I will tell you that's important to know is that when you use medication for weight loss, to keep your weight down, you have to continue the medication. In other words, a lot of times people think of weight as if it's like an infection or something that you can take antibiotics for, clear it up, and then stop the antibiotics and be fine. But it's more like taking medicine for blood pressure. If you're taking medicine for blood pressure and your blood pressure is normal, you don't stop taking the medication. You continue taking it to maintain your blood pressure being normal. So with weight, we don't cure it, just like with high blood pressure, we don't cure it. We manage it with medication. And in the case of weight, we can manage it with medication and or surgery. So the answer is yes, you can use medication. A little caution is that you should anticipate staying on the medication to maintain your weight. If you come off the medication, the overwhelming tendency is to regain the weight back.
Okay, thank you. I think Halima, I'm sure he has answered that question. The second part of your question is for Dr. Austin, though you are asking how can you book to see him. And I don't know whether if you saw the flyer that has been shared, whether online or not. If not, we can get your contact and send it to you. We're expecting the IMSA Medical Week is coming soon, and it's going to be from the 17th, from 14th to the 17th of April. So if you walk into Nisa Premier Hospital, you can ask anyone from the front desk, how can you see the GI surgeon, or how can you book for a procedure with see Dr. Austin, and you'll be attended to. If not, you can send a message, send your contact, and somebody will reach out to you, please. Thank you. Then Doctor, I think there's another question. Thank you, our own Dr. Ayoola. Dr. Ayoola, you now have a name. So thank you, our own Dr. Ayoola. Wachuku Blessing. Are bariatric surgeries reversible?
Thank you for your question. Yes, I heard. Thank you. So thank you for your question. Are bariatric surgeries reversible? It depends on the operation. So some operations are designed to be reversible, like the gastric bypass, and an operation that people don't do as much anymore called the lap band, where they put a piece of plastic around the stomach to separate it into two sections. Those are reversible. There's something like this sleeve where you remove a portion of the stomach is not reversible. Now, I get that question a lot, and I just want to address the underlying reason why people ask that question. Because if you think about it, if you have weight loss surgery and you lose weight and you feel great and life is good and everything's wonderful, you're not going to come to me and say, can you please reverse this bariatric operation because it's making my life too good. Nobody does that. The reason why people ask, is it reversible, is really to say, if we run into problems, if we run into trouble, if I don't like something about it, can I just go back? If I feel like I made the wrong decision, can I go back? And so the answer to that is that the problems we tend to see with a sleeve are, one, regaining weight, which reversing is not the answer for, and two, reflux or heartburn, which again, reversing is not the answer to. So the two most common problems that we see long-term with the sleeve do not require reversal. They require medication for heartburn, just like you would before having a sleeve. And then the answer to weight regain is additional therapy, not reversal of therapy. So yes, there's some that are reversible. The sleeve in particular is not reversible, but you shouldn't worry about that because the problems I've taken care. I do about 300 to 400 cases a year. The last I checked, at about 3,000 patients that I've operated on, and I see about 7,000 people every year. And I've been doing this for about 13 plus years. So I've seen a lot of patients. I've seen a lot of people's stories. People don't come back asking for reversal. They come back asking for additional therapy for anything that has turned up. So I would just encourage you. I know it's scary, and I know you worry that if I make the wrong decision, how do I reverse that decision? I'm telling you that that's not what people experience. What people experience is either joy and gratefulness from the weight loss, or they experience weight regain and want more therapy, or they experience heartburn, and we treat that with medication just like you would anytime anyone else has heartburn. It's rare that you have to treat heartburn with surgery. Yes, sometimes you have to, but again, that's not reversal. That's treating the problem of heartburn, if that makes sense.
And if I may add also, just for the lady that asked the question, when you have the surgery, you're not abandoned, that you're not being followed up anymore. When the surgical process as well as healing has occurred, if you're having any problems like heartburn, they will probably turn you over to the gastroenterologist, and we'll continue managing you to make sure that you're adequately controlled and that your heartburn is not, the cause of why you want to go reverse the procedure. That's number one. Number two, would also help you with nutrition to make sure that you maintain the weight that you've lost. And at the end of it all, I think most people that we see are happier to have done the procedure than wanting to reverse it. I can't think of any specific reasons that will make them want to reverse it, except if there are any complications that might need to be reversed. But I would dare say that those that I have seen, 90% of them would not need reversal. They would just need to continue seeing the gastroenterologist if they have any problems, as well as see the bariatric surgeon if it's something that it's surgical in nature. Thank you.
Thank you very much, Dr. Osemeka. Please, I want us to come back home for people here present. I'll give a microphone to one person to speak. Please, Ma, can you come up here?
Good afternoon, Dr. Ayoola. I think mine are more of worries. I know a little bit about the surgery. My worry is, number one, I know I will lose weight. I want to know if I will keep losing weight. Because I don't think that's what I want. I want to be able to get to a certain weight I can maintain it. How do I do that? That is one. My second worry is I need your advice. I am managing a sleep right now. It's okay to go ahead with the surgery, and will this surgery help me in any way, help my sleep state? And then lastly, I want to know how much it costs. Thank you.
Thank you. Thank you for your question. Well received. You're really testing my memory because you gave me three questions.
Dr. Ayoola, please, can you turn on your video? Yes, please.
Yes,
Thank
I can.
You.
Yeah,
Thank you, please.
no problem. No problem. So you asked me three questions, and I was just saying that you are really testing my memory to see if I can remember all three questions and answer them for you. So challenge accepted. Can you hear me?
Yes, we can hear you.
Okay. It looks like yours.
Let me take the questions one by one, because I'm really interested, and I want an answer to all my three questions. My name is
yes, I'll answer.
I did not introduce myself. I'm sorry. My name is Omalie. I am going to be 61 this year. So my worry, my question was, first one is, from the way you explain, surgery is not reversible, meaning I'll keep losing weight. So I just want to know, will it get to a stage, or do you have a technique at some point and I'm like, I'm okay with the way I'm looking, then I can maintain that weight? That's my first question.
Can you hear me?
Did you hear my questions? My question.
Yeah.
Sorry.
So your question, your first question is centered around your weight loss and how much weight you would lose. Okay.
Yeah.
And so the first thing I have to say is that there's really no way to um, to dial in an absolute weight for someone, because that's very dependent on the person as well. Now, we know everybody loses weight. Now, how much weight you lose and keep off is also dependent on kind of the things that you do, right? So I can't say that every patient I operate on will lose this exact amount of weight. I can give you an idea of how much weight most people lose. Now, that being said, everybody knows that the easier thing to do is gain weight, right? We know it's difficult to lose weight. We know it's very easy, very, very easy, too easy to gain weight. So when people worry about too much weight, I tell them not to worry about that, because it's so easy to gain weight that it's very difficult to lose too much weight, to accidentally lose too much weight. You have to be intentional to lose weight. So our issue is not going to be a problem of weight gain. It's an issue of weight loss. So you're not going to accidentally lose too much weight. Okay. So even though I can't tell you exactly how much weight you lose, because that depends on how well you watch your diet, how much you exercise, how intentional you are. All I can tell you is that to lose weight, you have to be intentional. It doesn't happen by accident. You have to be intentional. And so I don't worry about people losing too much weight with a sleeve. Okay.
Yeah.
You're,
so my
go ahead.
My second question is, I'm managing a slipped disc right now.
Okay.
I want to know if this surgery will help me, or even after the surgery, I have to do surgery to correct the slip disc. That's my second question.
Right. So that was your second question on how does this affect a medical condition that you already have.
Yes.
So this is, let's start with this. The extra weight you have on is putting more pressure on your disc. It's causing more problems with your disc. So surgery at minimum prevents that disc issue from getting worse. Okay. So at minimum, we're going to hold the deterioration of your condition so that it doesn't continue to get worse. If you have to have surgery on it, weight loss surgery, getting the weight off makes your recovery better. It makes you less likely to have complication. It makes you more likely to recover well and have a better quality of life. So it may not heal your disc, but it certainly prevents it from getting worse and getting worse quickly. Does that make sense?
Very much.
Yeah.
So my last question will be, how much will this surgery cost?
So that is a question that I will defer to the folks at Nisa and the business development, because, and the reason for that is simple, is there's a component that's my cost, there's a component that's their cost, anesthesia cost, and so on and so forth. And so I'm going to defer to them to give you a full cost rather than us giving us the split, because what you're interested in is what's it going to cost completely. And so that's something that
the folks there in person with you with the business development at Nisa should be able to answer for us.
Okay. So no, just a quick one. You know, you also mentioned the band.
Yes.
Won't it be the right kind of a surgery for someone like me that want to get to a certain level, and then maybe I can have the band taken off?
So kind of like how I was talking about earlier about people taking medication, thinking once they get to the weight they want, they will stop the medication and be happy and live happily ever after. That's not what happens. That's part of the reason why we don't do the band anymore. Because if you did I lose everybody?
No,
We are with you, sir.
Okay, it just looked like it.
Yeah.
So okay, the screen just paused out. If you put a lap band in and then remove it, people gain their weight back. And so you pay all this money to put a band in to lose weight, to remove it, which you pay money to do, and then you gain all of the weight back. In general, we just didn't feel like that was a reasonable thing to do. So again, anything you do to lose weight, if you stop doing it, you regain the weight that you lost. And so it's generally not recommended to go into this with a mindset of reversing what we do. You're much better off going into this with a mindset of wanting to lose weight and live well. And so the lap band is not done as much anymore because it's something that you have to reverse or end up reversing, and the patient regains all their weight.
It's NJ there.
I think we lost them over there.
We just had a brief technical issue, but we're going to be back in a few seconds now.
Okay. I'm being on my phone too.
Yeah.
On the move.
Dr. Ayoola?
Yes.
Okay, please, we can go on now.
Okay.
Sorry for that break in transmission.
No problem. No problem at all. So the last thing we were talking about was just why not the lap band? And what I was explaining is that we don't encourage the lap band anymore because the lap band usually has to get reversed. And when you reverse the lap band, people will usually regain all their weight. And so we don't, excuse me, we don't recommend it because of that.
Yeah, that's fine with me. Thank you, Mr. Dr. Ayoola.
Just hold on, please. Oh, gosh. Is it on? Is it on? Can he hear?
Yes, I can hear you.
Okay, Dr. Ayoola, can you please take this question from our online participants?
Sure.
One, I'm going to ask one after the other. He has 3 questions. One, how do I know which is the best option for me? I had a baby via CS 10 months ago, and I'm still breastfeeding. Would I be eligible?
Yes. Breastfeeding doesn't affect anything. We're not putting you on any medications that we're worried about being expressed in breast milk. I mean, obviously, around the time of surgery with anesthesia and things like that, I'll have the anesthesiologist comment on that. But from just the surgery standpoint, the sleep standpoint, there's nothing we're doing that prevents you from being able to move forward with the procedure from that standpoint.
So that because she had CS 10 months ago, she's qualified to come for the procedure.
Yes, once you're about 6 to 8 weeks out from the CS, you're able to have additional surgery. So being almost a year out from the CS, that's not going to be a problem.
Okay. So I'm talking about it on apps. Want you to reach out to us and we can tell you, we will prosper you once the process will be sent to you.
I'm sorry, you're breaking up a fair amount for me.
Yeah, I have some questions coming from people here in the audience. So please, I don't know who is for, Dr. Ayoola or Dr. Osemeka. Ma, please, can you go ahead?
Hello, I'm Ruth. So my question is, can you hear me?
Yes.
Okay, my question is a follow-up on the statistics you gave. You said you've seen about 3,000 patients a year?
No, 300 patients a year. Anywhere from...
Okay, so I just want to know if you have the data for those that come for treatment of things like PCOS and diabetes, you understand? And how effective is it on your data? The analysis.
Yeah, that's a good question. So there's a program called MIPSQIP, MBS-AQIP, and it's a quality program that is nationwide in the US. And that program requires that you declare every patient you operate on and what their outcomes were. If they had complications, if they resolved their medical conditions, things like that. So it's not just my data, it's also the data of all the surgeons in the country that participate in this program. And to participate in the program, your hospital has to be a center of excellence. I tell you all that to preface that I have two facilities where they're both centers of excellence, and I'm the medical director of the program itself, overseeing the other surgeons and the data and things like that. So I have robust data on what my experience has been, the data on what the national experience has been. We improve PCOS, we improve diabetes, we improve high blood pressure, sleep apnea. Depending on the operation, the amount of improvement is variable. So if something like the duodenal switch has a 99.9% resolution of diabetes. So if you're diabetic and you do a DS, 99% of the time your diabetes goes away. If you have diabetes and we do a sleeve, the number is not as robust, but it's still pretty high, 50 to about 70%, depending on the study you look at. And so in general, we improve medical conditions that are associated with obesity. Does that answer your question?
Okay, she has a follow-up question. Please hold on.
Thank you for those details. I'm just wondering now, do we have an option to have a one-on-one and then we're advised on which one is best for us based on our medical history?
Yes.
Or
yes.
just opt for one and all right, thank you. That's fine.
Yeah, the ideal scenario is to have a one-on-one, and your question is very astute. The ideal scenario always with medicine is to have a one-on-one because you can't do one thing for everybody and expect the same result. So it's important to speak with people about their own specific condition to determine which operation is best. I hope you were there for my presentation. I showed how there were three main operations. Yeah, so I showed how there were three main operations and I gave broad ideas. The sleeve is good if you don't have terrible heartburn and you're not diabetic on insulin in particular. But if you are diabetic on insulin or you have very bad heartburn, the bypass is better. And then the duodenal switch is good if your BMI, body mass index, is over 50. The way to identify what your body mass index is you can either download an app on your phone or Google, and it will and you get a BMI calculator, and that way you can calculate your BMI. If it's over 50, you do better with the duodenal switch. If it's under 50 and you're diabetic on insulin or have terrible heartburn or reflux, you do better with bypass. But if none of those things are true, BMI under 50, no reflux, diabetes, maybe on just metformin or glyburide or something like that, then a sleeve is a good option. But again, you can always and you should always personalize the decision. But I'm giving you the broad ideas that you should be aware of all the same.
Are you satisfied, Ma? Okay.
And if I may add for her also, remember that your care is coordinated between you, your primary care physician, that's the person that you see for your other diseases, Dr. Ayoola, who's the surgeon, who's going to take care of the post-op care. But at some point in time, Dr. Ayoola is going to drop you in terms of, well, you don't need to see me anymore. You've healed nicely. You're doing fine. But we don't just throw you out there. You now have to continue with your primary care and possibly with a gastroenterologist like myself. So what we're offering you is a coordinated and well thought out care. You meet and discuss the kind of surgery that's good for you. When you finish, the medical guys take over and make sure that you continue to lose weight in a safe way. And even when everything is going fine, you will still be having appointments to see your primary care or to see the gastroenterologist. So you should be rest assured that you're in good hands and you're going to be taken care of as you go along.
Thank you so much for that addition, Dr. Osemeka. Very, very, very correct. Thank you.
Yes, thank you very much, Doctor. Please, we have some more questions from online participants. Dr. Ayoola, the question says, what is the maintenance process for sleeves?
So the maintenance process is at minimum an annual checkup where we evaluate your weight and see how well you're doing. But right after the procedure, we want to see you back at 2 weeks to make sure you're recovered well from surgery. And then we also want to see you at about 3 to 6 months to see how your weight loss is going, to make sure things are going well. And then the further out you get from the day of surgery, your visits reduce. So normally here we do 2 weeks, 3 months, 6 months, 1 year, and 1.5 years, 2 years, and then we go to once a month. Not once a month, once a year. Once a month would be too much. Once a year. Okay, so the further out you get from surgery, we go into a once a year kind of follow-up. So the maintenance is really just making sure you're losing weight, making sure your diet is good, and that's what Dr. Osemeka was saying, that's not something I necessarily have to do. Sometimes the medical doctors take over and make sure the nutrition is good, make sure the lab work is good. We'll check lab work once a year just to make sure your vitamins are okay and things like that. Okay. So that's the follow-up. Again, here are some of my patients that have had the operation done and their results. So you can see like this young lady here in the red and how she is now. She's not coming to me asking me to reverse what she has. She's very happy with her health, her cosmetic look and things like that. You see the great smiles on people's faces and the pride they have in themselves afterwards. Folks like this are not asking for reversal. They're very satisfied with their presentation. So weight loss after the operations, I put this up because it speaks to both the follow-up at 2 weeks, 3 months, 6 months, 12 months, and the kind of weight that's lost in that time period, 10 to 15 pounds. 1 kg is 2.2 pounds. So I just roughly divide by 2 to get an idea. So this would be about 5 kg to 7 or 8 kg at 2 weeks, and so on and so forth. Now, again, I spoke about this earlier, that if you don't have this much weight to lose, your body won't give it up. So you won't lose. If you're looking and you're saying, I don't have 75 pounds to give up, or I don't have 20 kg to lose, once your body gets to a certain point, it knows to not lose more weight. It's actually very difficult for you to lose more weight once your body gets to a certain point. It may be hard to believe, but that's the tendency that we see. In terms of your long-term results, the sleeve, as you can see here, the total weight loss, it gets about 25% of your body weight. And then over time, you have to be careful because we don't want this 25% regain. So you can see that people lose weight over the first year or two, and then after 2 years, there's a tendency to want to regain weight, and this is why we do annual follow-up to prevent and arrest weight regain if at all possible. Okay, so that's the point of the follow-up. The follow-up is to make sure that people don't regain the weight that we've taken all this work to help them lose.
Okay, thank you, Dr. Ayoola. Thank you for the insight. I have more questions for you, please, if you don't mind. Dr. Ayoola, please, what happens if the weight loss becomes... Please, Kadiri Ejura, can you mute your mic? Kadiri. Please, can you mute your mic, ma'am? Dr. Ayoola, please, what happens if the weight loss becomes too drastic and unhealthy years after the surgery?
The weight loss doesn't get too drastic. The problem we see is the opposite. We just don't see that. You have to understand that the amount of calories your body needs to maintain a healthy weight is not a lot. And that's the reason why people have so much trouble losing weight, because the amount of stuff your body needs is not that much. And so for you to have drastic weight loss, you're not eating at all. And if you're not eating at all, there's a bigger problem. It's not just the weight loss surgery. There's something going on with you that is more severe than weight loss surgery. So the tendency overwhelmingly is not that we see a bunch of people. Again, like I said, I gave how many patients I've taken care of over my career. Last year, my practice saw about 7,000 patients in our clinic in 1 year alone. So we don't see people coming in. We just don't see it. So it's hard to answer a question about something that just honestly doesn't happen. Certainly not with a sleeve.
Okay. Thank you very much. So what's the approximate time from start to finish for each of this procedure? So I guess you're talking to both Dr. Ayoola and Dr. Osemeka. What's the approximate time?
Dr. Osemeka go.
Both of you, what's the approximate time from start to finish for each of the procedure?
For the procedures that I do, you believe it or not, they are usually less than an hour, because most of the endoscopies, if you do an open endoscopy, it takes me about 20 minutes to 30 minutes. However, that is not the total time for the procedure. I want you to accept the concept that safety is the most important thing that we put our money on when we do these endoscopies. The first thing that happens is that there is an intake process where you're evaluated the day you come for the procedure by the anesthesia people to make sure that we can put you to sleep safely. Then you're brought into the room where we do the procedures, and then I'll start after they've made you sleepy. In other words, you don't know what's going on. You're going to be under some form of anesthesia. And that's a little bit different from what I see happen in Nigeria. There are procedures that are done without sedation. But in the United States here, everybody gets sedated, at least to make them as comfortable as possible. And we can see how we can do that in Nigeria safely so that there are no bad outcomes. The procedure itself is done. And then there's the post-op time, the time that you go to the recovery area. We monitor your blood pressure. We make sure you're fully awake. We make sure you're safe to go home, and you go home. And all this will take not more than an hour. Thank you.
Dr. Ayoola?
Yes. Can you hear me?
Yes, can you mute, please?
I don't think I'm muted. Can you hear me? Can you hear me? Can you hear me?
No, each medical meeting there or not audit. I'm not part of the audit committee. They're auditing me now.
Dr. Wada, please mute your mic. Thank you, sir.
Can you hear me?
Yes, we can. Please go ahead.
So depending on the operation, the sleeve is about a 30-minute operation, and the bypass is about 1 hour, and the DS is about 2 hours. So the sleeve is the shortest, taking about 30 minutes.
Okay, thank you. Thank you for that clarification. There's another question. Can this surgery bring back my blood pressure back to normal? Bring my blood pressure back to normal blood test?
NJ, please, can I just make a comment before that question is answered?
Okay, please.
I like the question about the times for these procedures, but I think more importantly is doing the procedures in the right hands. You're getting Dr. Ayoola, who's more than 13 years, sees about 7,000 patients a year. It's like everything you do, the more you do, the better you are. So in as much as we want it done fast, we want it done safe, we want it done well. Any surgeon that you see, you really should ask about their complication rates. How much do the patients have to come back with problems? And that's why somebody of the caliber of Dr. Ayoola is coming to Nigeria to do those procedures because we want them done safely. The same thing with me. How many people will do endoscopy for you and be able to give you the right results at the right time with no loss of life? So please, as we check out the times, let's bear in mind that actually it's how well and how experienced is your operator. Thank you.
Thank you. I quite agree with you that safety is the key, is the watchword. Safety is just very key. The question is, can this surgery bring my blood pressure back to normal blood test? Dr. Ayoola?
Yes, can you hear me okay?
Yes, we can.
Yes, so for a majority of patients, the weight loss operations will resolve high blood pressure. For a majority of patients, at minimum, the amount of medication you take should reduce. So you have a good chance to resolve completely, but you also have a chance to reduce how much medication you have to take. And so overall, if you have high blood pressure, it is recommended to have surgical weight loss, especially if your BMI is also appropriate.
Okay, thank you very much, Dr. Ayoola. Thank you for the clarification. I have one. Is my heart is, but not a lot. I am type 2 diabetic, which would be okay for me. My BMI is 49.
So I think that, it's respecting the privacy of your personal health history. I would just generally say, number one, we can have a conversation about you specifically, probably one-on-one, but broadly speaking, if your reflux is not bad, if it's not too significant, you can still do a sleeve. If your diabetes is not too significant, i.e. you're not on insulin, then you can still do a sleeve. But generally speaking, if you take insulin, you're probably better with a bypass or a DS. Your BMI at 49, any BMI over 50 is when I like to do the DS for better weight loss. But you can stage that and you can do a sleeve first, see how you do with the sleeve, and then come back and break the operation up and do the second part of the operation at a later time to complete the DS. I have my slideshow up now and I have access to it, so I can kind of show you what I mean by that, if you don't mind. But I'll share my screen here. Okay, so this is the DS. And so with the DS, what you're doing is dividing the intestine in two places, bringing it up and attaching it, and then reattaching down here, and then doing a sleeve. So food comes down one part of the intestine, digestive juices come down a separate part, the two meet, and the red is where you absorb food. So this operation is good if you're a severe diabetic or if you have your BMI over 50, because it loses more weight and treats diabetes better. So you can do all this in one session, or you can do the sleeve first and see how you do with it. And then if we need additional support to treat the diabetes and so on, then we can come back and do the intestinal component. Now, this operation is very strong, 100 to 250 pounds weight loss. That's 50 kg to what, 100 and something kg. And it's very effective, as you can see with these patients of mine. These are all, I always show patients that are mine. So this lady in the red, she's 10 years out. The weight is still off. She's no longer diabetic. She's doing fantastic. This lady on the top left, she's about 8 years out. She's doing great, feels great. And so sometimes people wonder if I only operate on women. Here's a picture of a man that I did a DS on as well. You can see how unhappy he looked in the first picture, and you can see on his face how happy he is and satisfied he is with the weight loss he's seeing in the second picture. So that's what I would say broadly is if you are severe diabetic, i.e. you're on a lot of insulin, the DS is good. Once your BMI is around 50, the DS is good. But even with that, you can stage it and do a sleeve first, and then come back and do the second part of the procedure with the intestine. With the bypass, it's also better for diabetes. It's not as good for people with a BMI close to 50 because of the chance of weight regain, but it is really good for people with heartburn or reflux as well. So that's also an option. And as we've talked about with the sleeve, it's good for people with a BMI under 50, ideally no diabetes or at least not on insulin and no significant reflux. So those are the kinds of things that I would talk to you about one-on-one in detail to learn more details about these medical conditions so we can make a decision on what makes the most sense for you. Dr. Osemeka, do you have something to add, please?
Sorry, we're just trying to unmute. Yes, I think you're absolutely right. And if one looks at the physiology itself, how the patients do better after the DS itself and compared to the sleeve, I think the opportunity to have a sleeve and then convert to a DS is actually something that I'm also learning now, that it's doable and also something that can be done for patients that want to see how much weight they can lose. Thank you.
Thank you.
Okay. Thank you very much, doctors. So, Dr. Ayoola, these are the last questions for today, and we'll call it a wrap. What are some disadvantages of this weight loss surgeries? What is the mortality rate associated with it? And what possible complications could arise from the surgeries? So, I don't know, we can take all at once.
Yeah, I'd be happy to. So you notice on the slides I've been sharing, one second here. You notice, I'm going to share it again, but you notice on the slides I've been sharing that I always put the good and the bad and the ugly. Okay, so the question about what are the side effects on the surgery depends on the surgery. So you notice I always put good, bad, ugly. The good for the sleeve is it's low risk. The bad is 10% of people can get heartburn, reflux. The ugly is weight regain occurs in about 20% of people. Okay, with the bypass, The good is that it treats diabetes very well. It treats reflux very well. The bad is you can get ulcers, especially if you smoke. So I don't do it on smokers. If you're a smoker, I will not do a bypass because you will go back to smoking and you will get an ulcer, and that could be very, very bad. Dr. Osemeka can speak to that. And if you use NSAIDs, ibuprofen, Motrin, Aleve, those medications for pain, you can also get ulcers. So I caution people that if you have really bad joint problems and you take these NSAIDs, we need to think about what alternatives you're going to use. And then the ugly is something called dumping syndrome. Dumping syndrome is lightheadedness, nausea, diarrhea, but that's with sweets. And sweets also make you gain weight, but some people are sweet tooths and really like their sweets. So if you like your sweets a lot, we have to have a conversation about the dumping syndrome you may experience if you don't give up your sweets afterwards. And there are people that say, I'll take the nausea, diarrhea, and lightheadedness as long as I can have my candy. And that's a personal decision, but we have to talk about it very clearly before we move forward. With a duodenal switch, the good is the weight loss. It's the best weight loss. It treats diabetes incredibly well. You eat more food because your stomach is bigger with this operation. Lots of protein, lots of fat. So people enjoy the diet that comes with the operation. The bad, your farts are going to be stinky. Okay. I had a patient say he could kill small animals with his farts. Okay. They're super stinky. You have 2 to 4 bowel movements and then 3% malnutrition risk. This is the only operation where I can see people lose too much weight despite them eating normally and things like that, because we bypass or go past so much of the intestine with this operation that if you don't eat and eat a lot, you can lose too much weight. This is the only operation that I would say that you have a chance of losing too much weight, and we have to be careful how much intestine we bypass. Okay, so that's the answer to that question on what are the problems with the operation. Now, the second part, the second question was about mortality or death. Mortality rate with bariatric surgery is very, very low. It's less than 0.5%. It's less than 0.1%. It's safer in the US for sure. It's safer than getting out your gallbladder. Someone said earlier they had a C-section. It's safer than getting a C-section. I was speaking earlier about the MISQIP, MBS AQIP, which is something that was put together to really make sure that bariatric surgery was safe. And so there's been a lot of work over the years making bariatric surgery as safe as humanly possible. And we have gotten it very, very safe. It's safer than most operations that you've experienced. It's just as safe, if not safer, than getting out your gallbladder, doing an appendix, C-section, knee replacement, spine surgery. It's a very, very safe operation.
Okay, thank you very much. I think, I guess I'm very sure that we will have all had a very beautiful day. And our answers, our queries, both for our online participants and the online and offline participants, I guess our questions, our queries have been answered. And we're looking forward to welcoming patients who will subscribe to these procedures. Remember that this IMSA Medical Week will be, it has been scheduled to hold on the 14th through 17th of April, 2025. And it will hold here in Abuja at Nisa Premier Hospitals, where the two renowned surgeons, Dr. Ayoola and Dr. Osemeka, will be coming to Nigeria from the United States to perform these surgeries to patients who are interested. So we request that you sign up for this, take advantage of this period. Where if some people have asked for the price list of the surgeries, please get back to us. If you have your contact or on WhatsApp group or online, please send a message to anybody and we'll share the price list for you. I'm going to call on the Group Managing Director of Nisa Medical Group, Dr. Musa Shoibu, to give a closing remarks and declare this open day closed. Sir, are you ready? Thank you. Can take it from here, sir. GMD, sir.
Maybe while we're waiting for the GMD, I just want to make a comment on the complications and safety issues that were raised. And I just want to say that that is why we're coming to Nisa. You have to choose a place where you're comfortable with. You have to choose a doctor that you're comfortable with and his experience counts. And then you have to choose the right procedure. And I believe that with us coming to Nisa, this is not going to be the only time. It's going to be an ongoing thing. There would also be other specialists that are coming as part of the NEMSTA group. So you should have the confidence that these people coming are not coming just to come and go, but they're going to be around always to help you with your healthcare. Thank you.
We have the GMD now. Okay, GMD. Thank you. Please give closing remarks and this open day session to a close. Thank you, sir.
All right, thank you very much. Good afternoon or good day, good evening, all participants. Firstly, I'd like to start with some words of apology. Fortunately, unfortunately, I've been at another meeting, actually the audit committee of Nisa board. I apologize that I'm unable to join this. But however, the reports I'm having assures me that everything has gone very well. I want to thank, firstly, all our participants from all over Nigeria, indeed all over the world, the resource persons across the Americas. I know some of you are perhaps should be sleeping by now, but you sacrificed your time to be with us at this open day. We really, really appreciate you. Not only for all the insight, but for also giving back to your country. We cannot appreciate you enough. For the participants, I want to thank you for taking time to listen to us. I believe the experts, Nigerian experts who are on this call have shed more light into your various topic and maybe answered most of your questions. And we assure you that Nisa is never associated with anything less than quality. And we assure you of the best. On behalf of the CEO, Dr. Ibrahim Wada, I thank all of you for this open day program. And our prayer is that the project that we're embarking on should be executed very, very successfully. Thank you very much, and I wish you all a wonderful day.
Thank you, GMD. And with that, we have